Corn. Like you said, my name is Grant Whitaker. I just moved back to Florida about 4 months ago from Alabama to start my practice. So iron deficiency anemia is something that I get consulted on, probably 2 or 3 times a day in the outpatient clinic and probably a couple times a week in the inpatient arena. Key points of this talk is that all patients should have upper and lower endoscopy, especially if they're over the age of 50. We want to make sure we rule out any potential badness in their colon or in their stomach, mainly colon cancer. Menstruating women is a special class. If you can explain their iron deficiency anemia based on their menstruation, you probably don't need to scope all those patients. Something we're not doing enough of is testing for celiac disease. It's 1% of the U.S. population. So a lot of patients think they have celiac disease and gluten sensitivity, but we're not actually diagnosing it. And so that's a huge cause of iron deficiency anemia that goes undetected. I probably diagnosed celiac disease twice last month. And so it's just something that it is more common than you think, 1%. All patients should receive appropriate iron therapy. We'll go through that. That's pretty easy. And then when do you stop looking? And that's kind of a hard decision. And if you don't find anything in upper and lower endoscopy, when is it safe to say, we've done enough testing, let's just see what happens? So background, iron deficiency anemia, like I said, is very common. It's the most common nutritional deficiency worldwide. It's probably 2 to 5% of adult patients in the developing world have iron deficiency anemia. Probably about 10% of our referrals are for iron deficiency anemia. So we see it all the time, bread and butter. For premenopausal women, it's usually menstrual blood loss, but all other people, you need to consider GI blood loss as the #1 cause. Other things to consider, physiological conditions like pregnancy and lactation, a lot of iron being lost there. We've already mentioned menses, inadequate dietary intake. If they're a vegetarian or really on a specialized diet, we want to make sure that they're getting enough iron orally. Blood loss, and that could include blood donation, surgical loss, epistaxis, renal cell tumors are a big one that are easily missed. Part of the workup for iron deficiency anemia should include a urinalysis to see if there's blood in the urine. I've never actually caught one, but I think Dr. Sack was telling me earlier this week that he's caught 3 or 4 in his career. You diagnose the renal cancer that isn't having frank hematuria, but the UA diagnosed it. Chronic inflammatory diseases. We all know renal deficiency, but congestive heart failure and even obesity can lead to iron deficiency anemia. Medications, aspirin, NSAIDs, these are what keep us in business. I have stock in Goodies powder. That's my favorite medicine because it leads to a lot of GI blood loss. Other things that we're doing to the patient, we're putting them on acid suppressors, and acid is required to absorb iron. And so if these patients that are on PPIs for their lifetime, they might not be absorbing enough in their diets because they have such low acidity. GI diseases, and you'll see it spread out. Colon malignancy is probably the most, but peptic ulcer disease, inflammatory bowel disease, celiac disease, and then angiodysplasia in the bowel, H. pylori infection. So it's a pretty wide range of GI diseases, not just colon cancer, which is why the upper endoscopy is also an important part. How do we define anemia? Men, it's less than 13 hemoglobin. Women, 12. It's best to use a lower limit of normal for your lab because it varies. And then iron deficiency is defined by just when you have not enough iron, it reduces your erythropoiesis. You can't build blood cells. How do you make the correct diagnosis? Well, the gold standard, if you read the guidelines, is to do a bone marrow aspirate. I've never done one of those. No one does that. So we've got to look at secondary things. CBC indices are helpful. The MCH is actually much more sensitive to the MCV. So I take a look at the MCH. If it's low, they don't have a lot of hemoglobin in each blood cell, maybe indicating iron deficiency. MCV, the microcytic anemia, less than 79 or lower. But 40% of people with iron deficiency anemia have a normal MCV. So that's not a very reliable marker. If it's low, great. If it's not low, definitely doesn't rule it out. The iron studies, you can order a panel, you can order them individually. Ferritin is the most helpful. That'll be low. The other, I like the whole iron panel because it kind of can help you figure out, is this anemia of chronic disease or is it iron deficiency or both? The most useful test, like I said, is ferritin, but that's with the caveat in the absence of chronic inflammation, which is defined by a normal CRP. I don't always check a CRP, but if I'm really confused, I'm not sure if it's iron deficiency or chronic inflammatory anemia, I will check a CRP, and if it's elevated, I'll go on and do further testing. When inflammation is present, you can have iron deficiency, and your ferritin can be as high as 100. So that's something that can fool you if they have inflammation. Something you can check, a next step, and this usually isn't included in at least a standard hospital iron panel is a transferrin receptor. It's elevated. If you're iron deficient, your body's trying to grab as much iron as it can, so it produces more transferrin receptor to try to grab all that iron and absorb it. So if it's elevated, that indicates iron deficiency anemia. And it's not affected by inflammation, so it's a good tiebreaker. Something that's new that's not available commercially in the US but is being looked at in Europe is hepcidin. This is the main hormone that actually regulates iron absorption from the gut. So if it's low, that means you have iron deficiency. It actually inhibits absorption. So when it's low, your body's trying to hang on to as much iron as possible. It means that you have iron deficiency. When it's high, you can probably blame this on chronic disease. It's a test that is available in Europe, not in the US yet, and you may see it in the next 4 or 5 years, I would guess. Who should be investigated? Anyone that has anemia and iron deficiency should get endoscopy. Definitely men with hemoglobins less than 12, women less than 10 should be done sooner rather than later. You shouldn't wait 6 months. And lower levels of anemia usually indicate more significant disease. So endoscopy is usually where we start. You also want to, of course, do the history. Are they getting an iron deficient diet? Are they a vegetarian? Are they using a lot of NSAIDs? Do they donate a lot of blood? Have they had any major trauma or surgeries where they might have lost blood? Is there a family history of colon cancer? These might point you in the right direction. The exam, my program director would hate me for saying this, but usually adds nothing. You can examine the patient, and unless you find something unusual, an abdominal mass that you can feel, maybe you'll notice some signs of some systemic illness like Peutz-Jeghers, the top, the buccal dark spots, or HHT, the bottom picture of the telangiectasias on the lips. I've seen one of each of those patients ever, so they're not commonly seen. The rectal exam, even though everyone should get a rectal exam, that's something they teach you in GI fellowship. If you have a finger and they have an anus, you should do a rectal exam. It seldom helps because if they have hemorrhoids, are you not going to scope them? You're going to end up scoping them, so it doesn't really add much to at least in iron deficiency anemia. There's that urinalysis again, which is important, which is often not done, and the celiac screen. Just order a TTG. If it's abnormal, you've made the diagnosis. Endoscopy, upper and lower. If it's negative, you usually don't have to do small bowel endoscopy, or you do not have to get a capsule. You usually don't have to do anything, but we'll talk about when you should. If you detect H. pylori, either by a breath test or the stool antigen test, or on biopsy from EGD, it should be treated because that can contribute to iron deficiency. Importance of colonoscopy. If the ferritin's less than 100, you're 5 times more likely to have colon cancer. So that's why, especially in the population that's over 50, colonoscopy is the main test. And in Europe and in England, where they kind of regulate what procedures you can do in what order, you have to go colonoscopy first, and then if that's negative, they go on and do EGD next. Usually in the US, we just do both at the same time, so we can usually get that done. Easier on the patient to undergo sedation just once. When do you have to do a small bowel exam? Pill cam is usually what we do now. We usually don't go straight to double balloon endoscopy or the advanced endoscopy techniques. The pill cam is great. It finds an explanation 40 or 50% of the time. But if you look at the literature, seldom do we do anything about it. So it kind of gives you an answer, but if they have a lot of plebectasia or angiodysplasia, you're probably not going to go on and do a double balloon to eradicate each one of those abnormal blood vessels. Unless they're having overt bleeding and constantly being readmitted to get transfusions, it's usually not worth it. And so you can usually treat through it, basically. So even though the small bowel is very helpful in explaining things half the time, we usually don't go on and do anything about it. So I reserve those for people that are overtly bleeding or that are requiring frequent transfusions before I actually order that. Small bowel imaging. MRI, CT scan is less sensitive than small bowel, so don't even bother. If you're going to look at the small bowel, do a capsule if you can. And then barium studies, TAG-RBC scans, Meckel scans, there's no clinical indication for those. Possibly if they're overtly bleeding and bleeding quickly, they may be helpful. And usually in the iron deficiency anemia, it's occult, and so it's not going to help you in this instance. How do you treat them? It's fairly simple, is iron therapy, and usually oral iron therapy. It's cheap. The biggest complaint is intolerance to the iron, constipation, upset stomach, and that's usually associated with iron sulfate. There are different products on the market. I like Max FE. It seems to be better tolerated, especially by the elderly population. causes less GI distress. It has vitamin C and colace mixed into the iron tablet, so it kind of gets you past a little bit of constipation, helps absorption. It kind of anecdotal use that it seems to be better tolerated. But most people will tolerate ferrous sulfate. Just warn them that the stools are going to be a little darker. They might get a little constipated, so warn them to start some Miralax or some colace while they're on it. You can add vitamin C to enhance absorption. Intravenous iron. Vinifer is something that's used often if they cannot tolerate oral iron. Most patients can tolerate oral iron, though. There's even some literature now suggesting after major GI bleeds, we should be giving Vinifer to all patients before discharge because they lost a lot of iron with that major bleed. So that's something that can be done in the hospital or transfusion center, that if you have the little old lady that just cannot take oral iron, give her several doses of Vinifer, and that should take care of the problem. Blood transfusions, these should be reserved for people that really have a low hemoglobin or cardiac, pulmonary-wise, or unstable. Otherwise, give them iron and let their body build blood. Follow-up, what do? Well, you get their hemoglobin up to 10, 12, and then you want to check it and follow up at least every 3 months for a year to make sure that they don't become re-anemic. If they become anemic again, you can give them iron therapy again. If they don't respond to iron therapy, that's when you want to go ahead and do the capsule. But if they respond to iron therapy and their anemia resolves, then you don't need to do any further testing. You're done. And if you look at the literature, most patients will not have recurrent iron deficiency anemia if they had a normal EGD, a normal colonoscopy, and a negative celiac test. So you're safe. There's data to support you for not doing any further testing. Where do these rules fall apart a little bit? Again, premenopausal women, you kind of have to take this on a case-by-case basis. If you can blame it on their menstrual loss, or their iron deficient diet. Malignant tumors are very uncommon in this population, but have to be aware if they're having any overt bleeding. You definitely want to go ahead and scope them. If they're over 50, you definitely want to scope them just for regular colon cancer screening. But if they're less than 50, don't have any red flag symptoms, you can test for H. pylori, treat that, test for celiacs, and then probably not do much else. Pregnant women, of course, you want to avoid endoscopy in this population. It's common to have mild iron deficiency anemia in this population. Screen them for celiac disease, put them on oral iron, and then if you need to do any workup and it's safe to wait, do it after pregnancy. Patients with significant comorbidities. This is often the dilemma. You have the 85-year-old person that has a ton of other medical comorbidities. Do you need to go chasing their iron deficiency anemia? And that's just, you got to use your clinical judgment. It's probably, I would argue probably not a good idea, but if it's going to really make a big impact on their quality of life, well then go ahead and intervene. Gastric bypass patients are often iron deficient. The duodenum is a major source of iron absorption, so if you bypass the duodenum, you're going to have less iron absorption. They also have less acid production, and so they're going to absorb less iron. So they often will always be on an iron supplement, and you should monitor them appropriately. You cannot blame blood thinners or antiplatelet agents on iron deficiency anemia. It's definitely going to promote bleeding, but you have to investigate further. You can't just say, oh, they're on Plavix, that's why they're anemic, and don't look into that. And then what's the question about iron deficiency without anemia? This is actually more common than having iron deficiency anemia, but there's no consensus of what you should do about it. I usually screen them for celiac disease. If they're over 50, do your usual indicated colonoscopy to screen them for colon cancer, and then treat them empirically with oral iron and see if it gets better. But there is no guidelines for that. So that's the end. Key points again were you should test everyone for celiac disease. It's more common than you think. All patients, except for menstruating women, should have an upper and lower endoscopy. Use appropriate iron therapy and follow them up to make sure that it worked. And then if it doesn't, then you need to go look at the small bowel. So patients that don't respond to standard therapy, further investigation is warranted, but otherwise you're probably done. That's it. Thank you for your attention.